just do a little bit more of yak. Hopefully this is getting across here. So we're going to continue talking about these mesenteries. So, and I did have some questions about that, but it's good questions that will. The first thing I want to make clear is when I was talking about pleura, I was just drawing an analogy between what's going to happen with the GI tract versus what you've already heard about in terms of the lungs. So there's, of course, no pleura associated with the large with the GI tract. So the pleura is what I would refer to in general as a serosal membrane. So it's like I think the analogy I used was it's kind of like the epithelium that lines the inside of our mouth. It's a wet, thin epithelial layer. And I know, does epithelium have meaning to you? I know you haven't done histology yet, but it's just a sheet of cells that covers, in the case of the mouth, the inside of the oral cavity. It's a little bit secretory, it's usually wet. So the lungs have this serosa associated with them. The part of that serosal membrane that's attached to the lung is visceral pleura, and then it reflects off the lung to be continuous with the parietal pleura, which is attached to the thoracic wall. So the same type of thing happens with the intestine, except that the intestine, instead of being like just a lung, a thing like this, it's got all these coils. But imagine all those coils going into the balloon. The part of the balloon touching the GI tract, all the coils, is visceral peritoneum, and then it would reflect, the visceral peritoneum would reflect off of the tube and become attached to the abdominal wall, and that's what we would call parietal peritoneum, okay? And then the space, the inside of the balloon, in the case of this little diagram, is the cavity. It's either like the pleural cavity for the lung, or in the case of the GI tract, we call it the peritoneal cavity. So that's the difference between the abdominal pelvic cavity, which is just this space. If you take all the GI tract out and all the mesenteries out, you just have the abdominal pelvic cavity. But if you put the GI tract in along with its peritoneum, now we can create the peritoneal cavity, that portion of the space that's between the visceral peritoneum and the parietal peritoneum, just like you pointed out. So let's just look right here. Here's the parietal peritoneum on the posterior abdominal wall. And as we go up here, we see where it reflects off of the wall and follows this structure, which is labeled mesentery. That's mesentery proper. But you can see it goes out here and just begins to encircle each of these cross sections. So out here, we would refer to this as visceral peritoneum. And then this space, this dark area right here, which is between the parietal peritoneum on the wall and the visceral peritoneum on its way to the organ, this is the this would be the peritoneal cavity. Is that good? That makes sense? But then when you look around here, you see all these spaces between these transected portions of the GI tract. That's also peritoneal cavity. So as we'll see later, when you actually look at a cross section through, say through someone that's had an MRI or something like that, it's an image. There's almost no space. All these, the space is all taken up by the GI tract, but the peritoneum, which is a serosa, which means it's an epithelial layer that secretes a very lightweight oil almost. It's very slippery. Even though these segments of the GI tract are touching one another and moving across one another, unless there's some kind of disease or infection, they don't stick together. It's very mobile, very slippery. Okay, so that's, and we'll go on here and talk about a few more details about the mesentery, but there's one important concept that I want to get across to you right now, and that is the business of intraperitoneal versus retroperitoneal. peritoneal. So I've emphasized here as we went along that parts of the GI tract, like the jejunum and the ileum, are mobile, and they can be moved around. They're kind of attached to the posterior abdominal wall, but you couldn't just grab the small intestine from one spot and just lift it out of the abdominal pelvic cavity. So it's got these attachments to the posterior abdominal wall, but still the outermost layer that we were looking at in this diagram is that serosal layer. The outermost layer completely surrounds the tube. And this drawing kind of illustrates that. If we look at this drawing right here and imagine what we were just talking about right here, where we have parietal peritoneum on the posterior abdominal wall. Here we have that same peritoneum on the posterior abdominal wall right here. But see how it reflects off and makes this thing they're calling mesentery? That would be the same as right here. Okay, and you can see how we would refer to this as a double layer. So the peritoneum is on the posterior abdominal wall, but then it reflects off like this to make this double layer of two serosal layers running together. And then they split when they get to the GI tube and completely surround it, forming the outermost layer of the GI tract. Okay, so there's a term in histology you may not be familiar with yet, that's okay. It's called adventitia, where there's just connective tissue on the outer region of an organ, and it's attached to some other part, like the abdominal wall, posterior abdominal wall. But in this case, you don't have an adventitia, you have a serosa. Yeah, and again, that would be like the lining of the inside of the oral cavity, a very thin epithelial sheet that's wet, and that's what would be surrounding the GI tract here. So this is referred to, this would be an example of the stomach, of the jejunum, of the ileum, of the transverse colon. They would look exactly like this. So they would have this attachment by a mesentery to the posterior abdominal wall, and then the mesentery would surround those regions. There are other parts of the GI tract that I mentioned that are stuck to the posterior abdominal wall, and they're referred to as retroperitoneal. And examples that we mentioned already would be the descending portion of the duodenum and the transverse or third part of the duodenum. They're attached directly to the posterior abdominal wall. The ascending colon, the descending colon, they are referred to as retroperitoneal. And so instead of looking like this, here's the parietal peritoneum that approaches, say, the ascending colon, and then just goes over its anterior surface, and then comes back down on the other side and continues on its way. This portion of the second and third portions of the duodenum, the ascending colon, the descending colon, are like this. They don't have a serosa on this portion of them. Instead, it's attached directly to the posterior abdominal wall, so when you like if you were in a surgical field or dissecting a donor and you grabbed onto the ascending colon, you couldn't just lift it up. It's stuck to the posterior abdominal wall. It's referred to as retroperitoneal. This doesn't matter, but when you get to embryology, these organs that I just mentioned are going to be called secondarily retroperitoneal because they initially in the fetus were intraperitoneal, but then they just kind of outgrew their mesentery and got secondarily attached to the posterior abdominal wall. There are organs that are retroperitoneal organs, and one of them, I think I didn't mention this when we talked about the urinary system, but the kidneys are retroperitoneal. They form in a retroperitoneal region of the abdomen. So, okay, that's pretty clear. pretty clear. So let's see. So let's look now. We've seen this image before, and we were just talking about the GI tract itself, the esophagus and the stomach. And we mentioned the stomach in terms of greater curvature, lesser curvature, and we saw these sheets attached to it. These also are like specializations of the mesentery that we were just talking about. So what happens in the case of this big apron, you could actually, you don't see the inferior end of this apron down here, but it's a large, this actually is mesentery that's coming off of the posterior abdominal wall. It surrounds the stomach, but then comes off of the stomach at the greater curvature and just forms this big apron that hangs down over the GI tract. So I know often when we, on that day when we open up the abdomen and the students are expecting to see in small intestines and large intestines, and all they see is this big sheet of adipose tissue, and like, what is this? And then they hear about the greater omentum. You could actually go down to the inferior end of that omentum and actually lift it up like an apron. And then you see the small intestine underneath that. You can see through it right here. You see some of the transverse colon and a little bit of the small intestine here. So the lesser omentum is the same thing. So there's this omentum or mesentery that's surrounding the stomach, but at the lesser curvature, the serosa from the anterior and posterior side of the stomach come together, form this double layered sheet of mesentery, which then ascends and is then going to break apart again and surround the liver and the gallbladder and all this other stuff that we're going to talk about later. So this is referred to as the lesser omentum, connecting the lesser curvature of the stomach to some of the glands here, like the liver. That's, I think, maybe a little bit hard to imagine. So now what we'll do is, I'll start here. The next slide, in order to kind of get into these mesenteries a little more thoroughly and see how they organize the GI tract. Imagine here that we grab the inferior end of the greater omentum, which we really don't see here. And as I said before, we lift that up like an apron. So if it were me, we'd do this, okay? So there we have it. We've lifted up my greater omentum. And now what we're seeing is the small intestine, so the jejunum, the ileum, ascending colon, transverse colon, descending colon. Here's the lifted up greater omentum, okay? So the ascending colon is going to be attached directly to the posterior abdominal wall because it's retroperitoneal. We just can't really move that around very much. The descending colon is also retroperitoneal. We can't lift that up very much. But as we're going to see in a little bit, the transverse colon actually has a mesentery attaching it to the posterior abdominal wall. We don't quite see it yet. Before we see that, what we want to do, we're going to put our hands in here now. We're going to put them right here between just medial to the descending colon, and then we're going to take the small intestine and kind of move it up this way towards the upper right quadrant. And look what happens when we do that. We can move it, but it's still attached to the posterior abdominal wall by this big sheet of mesentery right here. This is what's called the mesentery proper. So the mesentery proper has a root that's attached to the posterior abdominal wall. It's right here. That area is about 6 inches long. But I mentioned before, how long is the small intestine? Yeah, so 20 feet. So you go from this 6-inch root where it's attached to the posterior abdominal wall, it has to spread out to be like almost 20 feet long so it can surround the entire length of the jejunum, and the ileum. So this is what you're seeing right here as it begins to spread out to cover all those. But still, you can see the small intestine is mobile, but still contained. It's like it's on a leash. Now, the next thing I want to do is we're going to go back to this picture. What we're going to do is go to the next slide, and we're going to elevate the greater omentum, but we're also going to grab onto that the large intestine, the transverse portion of the large intestine, and we're going to lift that up. Yes?
On the previous slide, it mentioned two sacks. The sac is referred to the area.
Oh, yeah, I better come back to that. I should have mentioned that. That's a good point. I just forgot that. Remind me, I'll finish what I'm talking about here, and then we'll go back and talk about greater sac and lesser sac. Good, thanks for pointing that out. Okay, so, yeah, we'll come back here. But now we're going to see where this is. We're gonna put our hands down here. We're gonna grab this transverse portion of the large intestine, and we're going to elevate that. And here we've done that. Here's your hand. You've grabbed onto the transverse colon, and you've elevated that now. But there's only so far you can take it. You can't just lift it out. It's attached also to the posterior abdominal wall. Do you see that? By this sheet right here. This is called the transverse mesocolon. That's just kind of the way these things are named, mesocolon. Now you go over here to the left, and here you have the left colic flexure and the descending colon. If you moved your hand from here, from the transverse colon, grabbed on to the descending colon and tried to lift it or reflect it out the way you did with the transverse colon, it wouldn't go anywhere. So it is retroperitoneal. It's got visceral peritoneum covering its anterior surface, but the posterior surface of this tube is attached directly to the connective tissue on the posterior abdominal wall. So it seems like a lot of detail, but for example, the surgeons that deal with colon cancer, for example, I mean, this is just their field of work. They know all the fascial planes, they know, it's just very important to them. But this gives you the concept of intraperitoneal, retroperitoneal. Now as we go down the descending colon, we come to this portion that we call the sigmoid colon. Now, if you moved your hand down here, grab the sigmoid colon, you could actually begin to flop that portion of the GI tract around. It has a mesentery attached to it, and then also attached to the posterior abdominal wall here. This mesentery right here is referred to as the sigmoid mesocolon. And then the rectum down here, it's retroperitoneal. It does not have a mesentery. Now I'm just gonna back up. This is okay, we'll go back here. So I'm gonna start off with this part saying we've opened up the anterior abdominal wall now. We've gone into the abdominal pelvic cavity. But we also have this other cavity we built now called the peritoneal cavity. And we said that's the space between the parietal peritoneum and the visceral peritoneum. Okay? So when you look at this picture, can you imagine where is the peritoneal cavity? Well, if I just took my hand and put it down on that GO, which is greater omentum, my hand would actually be in the peritoneal cavity. The palm of my hand would be on the greater omentum, which is visceral pleura, but if the anterior abdominal wall's been cut off, but imagine it's just a flap here, and you could fold it back over, that's where the parietal peritoneum would be. So that parietal peritoneum would be then covering your hand. So your hand would actually be in the peritoneal cavity, okay? The peritoneal cavity gets subdivided. There are quite a few subdivisions, but there are only two elements of this that I really want to talk to you about. We'll talk about greater sac, and lesser sac. So going back to where my hand is here, when I place it on the greater omentum, it would actually be in a region of the greater sac. The lesser sac is this tiny space posterior to the lesser omentum here, this mesentery sheath that's attached to the lesser curvature of the stomach. So that lesser omentum is attached over here on the left to the distal end of the esophagus, the lesser curvature, and then it just comes on to the duodenum right here. Here's the pyloric sphincter, so here's the distal end of the stomach, here's the duodenum. And then where this star is, I didn't add that star or the arrow, that was part of the figure. You could actually take your finger and put it behind this free end of the lesser omentum here, and your finger would go into the lesser sac. And it's this space posterior to this sheet called the lesser omentum. That's the lesser sac. Everything else out here is part of the greater sac, and together, those two sacs make up the majority of the peritoneal cavity. Okay? The lesser, this lesser sac, it seems, I mean, it's important clinically and surgically. If there's an ulcer in the stomach, often if any contents leak out of the posterior wall of the stomach, and this happens too often, it ends up in this lesser sac, and a patient, whether they're standing or bedridden or lying in a bed, that lesser sac doesn't drain. It doesn't have any place to drain to, so that this can be the site of a lot of surgical procedures. Are you okay here? A question or clarification? Yeah. The lesser sac is posterior to that part called LO where the pointer is. It's just, so that lesser omentum is the anterior wall of the lesser sac. Yeah.
So the part that is, below the greater omentum, is that also the, inferior sac, or the lesser sac, or
So this would all be greater sac here.
in front of it, or?
In front of it, behind, if I put my hand behind the, like between, on the small intestine with the greater omentum coming over, greater sac.
Okay.
The only way into the lesser sac is through that little opening, and it really is like big enough for your finger to go through, and then it expands a little bit, so this will be not easy to imagine, but the floor of the lesser sac is going to be that transverse mesocolon. So it's and the only way that clinically, the important part about this lesser sac is the only way to get anything out of any fluid or accumulation, like if there's an infection back there and you get ascites fluid, the only way to get out of there is through that little space here. So that's the only connection between the greater sac and the lesser sac.
Dr. Ansel,
Yeah.
So is it safe to say that the mesocolon is attaching the large intestine to the retroperitoneum?
Okay, the question is it safe to say, is the transverse mesocolon attached to the,
Retroperitoneum.
so when you say retroperitoneum, I would say it's the transverse mesocolon is attached to the posterior wall of the abdominal pelvic cavity. There is a space called the retroperitoneal, we call them retroperitoneal organs, like the kidneys, which are posterior to the parietal peritoneum. They have nothing to do, they never touch the peritoneum at all. So, does that kinda,
No, that answer, I'm just gonna have to remember that posterior wall of the abdomen, the mesocolon attaches to the posterior wall.
yeah, yeah. So with the kidneys, which are retroperitoneal organs, they're surrounded by that perinephric fat, for example, and then the parietal peritoneum would be covering over that fat. The kidneys are posterior to that, they just never see the peritoneum. So, okay, good. So, All right, what else here? Yes? The transverse colon is intraperitoneal, so it's completely surrounded by visceral peritoneum. But that visceral peritoneum then comes off of the transverse colon and forms a mesentery that attaches to the posterior abdominal wall. So we can move the transverse colon around a little bit. The transverse mesocolon forms that leash. And the transverse mesocolon itself is attached to the posterior abdominal wall. Okay, so there's one other part about this. We were looking at this, we saw the transverse colon, we saw the transverse mesocolon here again, so that's surrounding the transverse colon, but then the double layer comes together and attaches to the posterior abdominal wall. We saw the sigmoid mesocolon here, and we understand that this part of the descending colon is retroperitoneal. This is the ascending colon is retroperitoneal. I want to just look at this drawing here. I think it's always instructive to look at the painting. This is a famous, Frank Netter painting. What can you tell me about the small intestine here? What happened in the dissection here? Cut it out. Yeah, that's good. So now we want to add a little bit of anatomy talk to that. So there had to be 2 transections, right? So where did we cut it? At the jejunum, at the proximal end of the jejunum. Sometimes we'll say near the duodenal jejunal juncture. So that would be it right here. So the duodenum would be coming, it's on the posterior abdominal wall. We don't see it. It would be coming over here. It's retroperitoneal until it gets over close to the jejunum, and then the jejunum is intraperitoneal. So it would have this mesentery around it. So we transected it here. This, see all this accordion type thing? This is the mesentery proper, or the root of the mesentery proper. That was transected. And then here's the ileum. It's the distal end of the ileum. They just left the part that attaches to the ascending colon. Okay, so those are the 2 transections. And then once you've cut this mesentery, you actually can lift that entire small intestine out of there. So that's what's happened there. And then here's just a little detail. We're looking again at this box where the ileum joins the ascending colon, and we go inferiorly here into this region we refer to as the cecum, and we see the Taenia coli. We follow that down, and then we see the appendix coming off. The appendix actually has this little mesentery associated with it called mesoappendix, the mesoappendix. So this is important. I had a video, but I think I'm not going to be able to play the video. I just don't. I think the link is there if you want to play it, but I think this was a laparoscopic procedure where they take the appendix out. But in an appendectomy, you kind of understand the parts now. Once you get into the peritoneal cavity, what they do is find the cecum and then locate the appendix. They find the mesoappendix and use blunt dissection to just break that down and locate the appendicular artery. We haven't talked about all the branches of the arteries yet. We're going to do that, but there is this little artery in the mesoappendix that's giving little branches off to the appendix itself. They'll dissect that apart, put a ligature around the base of the appendicular artery, and then just put ligatures around the base of the appendix itself. Pop it out. Okay, so let's talk about the arterial supply now. So I'm going to back up. I'm going to try something tricky here. I'm going to back up to this slide right here. So we're gonna talk about blood supply, the arterial supply. The branches to the GI tract are going to come from the abdominal aorta. You know that, you already know the names of these arteries, celiac trunk, superior mesenteric and inferior mesenteric arteries. So if we imagine the aorta is back here attached to the posterior abdominal wall, and it is a retroperitoneal organ, so it's not associated with the peritoneum at all. But it gives off these branches. How do they reach, say, the small intestine? Through the mesentery. Did you just look at the picture and know that, or has somebody told you this already? Yeah, good. So this is good. So the aorta would be here. This looks like a little tube, but in fact it's that whole, remember the root of the mesentery that was cut off that spreads out to be like 20 feet wide? So it's a double layered sac just like here, and what's inside that sac? Mostly visceral adipose tissue. It's a fatty layer. Again, even in lean people, that's just where we store a lot of energy. But the arteries are going to go out through there, and that will take them directly to the wall of the gut, where they'll then spread out and fill the capillary beds out there. The other things that would be running through this space would be nerves. So autonomic nerves, we have to have sympathetic and parasympathetic nerves getting out there, and lymphatics. So we're going to have lymphatics draining the wall of the GI tract and all this other space, and they're going to be lymph vessels and lymph nodes in this space. Question? So the cisterna chyli, the origin of the thoracic duct, would be more associated, it would be retroperitoneal. It would be associated with the aorta. But these ducts that would be, or the little channels, the little lymphatic channels that would be coming through this space right here, of course, they would ultimately be connected with the cisterna chyli. They'll go through a lot of lymph nodes before they get there. And when you talk about, when Dr. Olgan talks about the digestion too, she'll be talking about the lymphatic channels that are actually taking up not just extracellular fluid, lymph fluid, but in the case of the GI tract, it'll be taking up fat that's been absorbed from the GI tract itself, because that's going to go, that doesn't get absorbed directly into the bloodstream. So the lymph is important for that. Let's see if I can, okay. So this is where we were. We're gonna talk about the blood supply. So now, here we have the dorsal aorta, again, this retroperitoneal organ. As it comes through the diaphragm here, it's going to give off its visceral arteries, the celiac trunk, superior mesenteric artery, and not showing the inferior mesenteric artery here, but you can see the vessels now traveling through the mesentery to reach the GI tract. So when we look at this picture now, they have the peritoneal cavity itself, that region of the peritoneum between visceral and parietal pleura. They have several different colors here. The pink, what might you think of as the pink? That's the greater sac. So do you see the lesser sac? It's the blue. So that green is, they're just distinguishing another part of the greater sac that's anterior to the greater omentum. I think that's my guess on what that is, but that was very good. So the pink and the green is actually greater sac, and that blue part posterior to the stomach, but also posterior to the lesser omentum, which is right here, is that greater sac, just very confined area. So let's look at some of the details now. So I don't want to push this too hard. I do have some of the branches of the of some of the vessels, but the big picture, I think, is more important than, all the names. So we will try to remember the celiac trunk, has 3 major branches. We'll remember that, and I listed them here. So the celiac trunk itself is quite variable. It'll usually be pretty short, and then divide into these 3 terminal branches. One is the splenic artery, and the spleen has nothing to do with digestion, but it's right around the foregut. So even when we dissect the foregut organs, we talk about the spleen. Here, the spleen is over here in the left quadrant. It's an intraperitoneal organ. It's part of the immune system, and it has this big artery that comes off the celiac trunk, runs from the trunk over towards the left on its way to the spleen. But for our purposes, it's going to be giving off a lot of branches to foregut organs, including the pancreas. But I'm thinking we don't have to talk about the pancreas now, and we will talk about the details of that later. It will also give rise to some vessels that supply the stomach, and we don't need to name those. And then the other branches that come off, another one is the left gastric artery. That's the smaller one right here. It's going to do, as its name implies, part of the stomach. It'll also do the distal end of the esophagus. And then finally, we have the common hepatic artery. So that's hepatic, referring to liver, so we'll talk about this artery next week when we talk about the liver. But it has some branches, pancreatico-duodenal branches. I don't have those names listed here, I don't think, and so I'm not gonna ask you to remember those. But you do remember that the celiac trunk is going to be supplying the foregut organ, so it's going to be supplying the stomach, the distal end of the esophagus, the stomach, the proximal portion of the duodenum. Okay, so that's, and then also on this picture, if we go just inferior to the celiac trunk, there's going to be another large artery coming out of here, the superior mesenteric artery. We don't see it. We don't see the origin because it's posterior to the pancreas here. We'd have to remove that. But you can see the superior mesenteric artery here coming out of the, associated with the inferior border of the pancreas. And this is the one that's going to spew out into the root of the mesentery and go to all 20 feet of the small intestine. It will also go to the ascending colon and to the proximal 2/3 of the transverse colon. So here's a picture then of the superior mesenteric artery. So what have we done here in this picture? This is just helpful again. So I guess this is the picture we were just looking at. Here's the superior mesenteric artery. So what have we done here? First of all, we've transected the stomach near the cardia, gone through the body of the stomach, and we've transected the duodenum here. So that's allowed us to remove the stomach, the main portion of the stomach. So we look through the lesser sac here, right? We've taken away the lesser omentum. This would be the area of the lesser sac. We've taken away the parietal peritoneum that would be back here, covering the retroperitoneal organs, and we've also taken away the pancreas. And that allows us then to see the aorta coming down through here. And here's the origin of the superior mesenteric artery. And now we've stripped away some of the visceral peritoneum that was making the mesentery proper. So we're looking into that space between the 2 layers of mesentery. And what we see are the branches of the superior mesenteric artery. The branches up here we would refer to as jejunal branches. And then as we get down in this region, we would talk about the ileal branches. I guess there are some named vessels, and I did put them in here. So the ileocolic, if we follow like this guy, I think, I can't read these little abbreviations or the names here, but this artery coming down to the area where the distal ileum joins the ascending colon, this would be the ileocolic artery, and it's going to give off ileo branches here to the distal end of the ileum. And then the colic branches, colic referring to large intestine or colon, here are colic branches, so that's an ileocolic artery. And then there's a right colic artery, you can kind of see that right here. And it's going to form an anastomosis with the colic branches of the ileocolic artery. So this is getting, we're wading into a lot of details here. The other branch that I mentioned here is the middle colic, and it's been transected here. Actually, in the next slide, we'll see that more clearly. So we're going to be looking at this very proximal portion of the superior mesenteric artery. And look here, it's important to see that we've transected the transverse colon and removed the entire distal 2/3 of the transverse colon here to look back at the aorta. So when we look at another picture, we're still, here's that picture we were just looking at where the transverse colon is removed. If we magically put the transverse colon back in place now, and we have the pancreas has been removed, here's the superior mesenteric artery, the proximal end of it, and you see this artery coming off of it that travels through this structure right here. What's this mesentery called? Transverse mesocolon. Good, okay, close. So here's the middle colic artery that's running through the transverse mesocolon, then it spreads out into left and right branches and supplies the transverse colon, okay? So we have right colic going to the, that makes sense, going to the ascending colon on the right side. We don't have a left colic here. That's the descending colon over on the left side of the abdomen is part of the hindgut, so we're going to have a different artery, the inferior mesenteric artery, that's going to supply the descending colon. And so now if we go down the aorta, there's this smaller artery that comes off again, right off, it's unpaired, it's coming off the anterior surface of the aorta. It's going to go towards the left, and it gives off a left colic artery that goes over to the descending colon. It will also do the region of the splenic flexure. And then there are sigmoid branches that go through the sigmoid mesocolon and supply the sigmoid colon. There's also a superior rectal artery that's disappearing down into the true pelvis, and of course that's going to supply the rectum. The rectum has some other arteries that I'm not going to tell you about right now just because it gets too complicated, but superior rectal coming from the inferior mesenteric artery is a major supply to the rectum. Okay? So that's pretty much the arterial supply. So the venous drainage of the GI tract is, we can start off saying it's pretty straightforward. There's going to be inferior mesenteric vein, superior mesenteric vein. There will be a splenic vein. There won't be, we don't really have a celiac trunk vein, but we do have a splenic vein. So, but if we think about the venous drainage of the GI tract, it's a little bit different than venous drainage, say, from the lower limb. You learned that there are veins draining the lower limb that go into the inferior vena cava, ultimately, right? And then where does that go? To the right atrium. The gut has this, of course, special function. It's involved in absorbing nutrients. Those nutrients, except for the fat, they're going to get into the venous system. And that blood is not going to go directly to the right atrium. It's not going to go directly to the heart. It's going to reach another capillary bed. This capillary bed is going to be in the liver. This gives the liver cells a chance to take up from that venous blood the nutrients that were absorbed from the GI tract. So we have this concept of portal systems. And you've talked about a portal system here, so this is a big one. So the venous blood is drained from the venous venules that are draining the intestinal wall, and then that blood is carried to the liver capillaries, which we refer to as sinusoids. The hepatocytes in the liver take up what they want. And then those liver sinusoids, this is getting ahead of the game, they drain into hepatic veins, which join the inferior vena cava. And then, of course, that blood goes directly to the right atrium and start over again. So here is the veins that are draining a majority of the small intestine. So, of course, those are going to be draining into the superior mesenteric vein. And I guess looking at this picture, I'm not sure, I didn't mention when we were looking at the arteries, we have, I'm gonna just tell you one other thing and then go back to that vein picture. Notice how these jejunal and ileal branches go out through the mesentery towards the wall of the GI tract. But notice how they start to make these loops. They're called arcades. See how these are direct anastomoses. So it's very hard to have a stroke of the GI tract because you have so many anastomotic connections, although it is possible to have basically a stroke of the GI tract and you get a diseased portion or a dead portion that just cannot pass a peristaltic wave, and that has to be dealt with. And then so you make these anastomoses, these arcades, and then see these straight arteries coming off. These are called straight arteries, or sometimes you'll see the term vasa recta, just straight vessel. They are the main connection, the direct connection between the branches and the wall. So looking at this vein picture, that reminded me that I hadn't mentioned that you can see, you can imagine capillary networks in the tube, and they drain into these straight veins, straight vessels, and then through the arcades and into the branches. Here's the superior mesenteric vein, and it's actually going to be joining right here with the splenic vein, which is draining the stomach, part of the esophagus, part of the duodenum. Those two vessels come together and they form the hepatic portal vein. And that vein is going to enter the liver, and we'll just leave it right there. This is just some other connections. We've taken some more organs out. We can't see all of the veins that are forming the portal vein. Here the pancreas is in the way, this large intestine's in the way, but if we take some of that stuff out, now we see all the elements that form the hepatic portal vein, which is right here. Here's the inferior vena cava on its way to the heart, carrying blood from the lower limbs, for example. But here's the superior mesenteric vein, here's the inferior mesenteric vein, and here's the splenic vein. And all three of those are going to come together to form the portal vein and carry that blood directly into the liver. And it's actually, this arrow right here is actually pointing to the free end, the free margin of the lesser omentum. There's a structure in here, several structures we refer to as the portal triad, but one part of that triad is the portal vein. That's all we need to say about that. Oh, we're supposed to take a break. I'm still talking. We're almost done. Let's just take a break and then we'll go through the lab pictures and look at some of this stuff.